Hello, everyone. Welcome to today's webinar. My name is Dr. Maggie Bartlett. I'm thrilled to be your host for the Global Virus Network Forefront in Virology webinar series. We have an exciting and informative session planned today featuring Dr. Gotuzzo. Before we begin, I just want to thank our sponsors for making this event possible. I'd also like to acknowledge all the attendees who are out there from around the world. Your participation and sharing of webinars like these are what make it such a success, and we're grateful to have you with us today. For today's webinar, we're going to be focusing on HDL1, and we'll start with a presentation by our esteemed speaker, followed by Q&A, where you'll have the opportunity to ask questions and engage in a discussion. Just a few housekeeping items before we get started. This session is being recorded and will be available to view after today's event. If you have questions during the presentation, please type them in the Q&A box, and we'll address them as many as we can in the Q&A segment, or feel free to use the chat function to engage with other participants and share your thoughts. Dr. Gotuzzo is an Emeritus Professor and former Director of the Instituto de Medicina Tropical Alexander Humboldt at Universidad in Peru, and he has had many esteemed positions, including the past president of both the International Society for Infectious Diseases and has served as the president of the 19th International Congress on Human Retrovirology, HTLV, and related viruses, in South America representative for the International Retrovirology Association. He is an honorary member of the Medicine National Academies of Mexico and Peru, and a member of the Institute of Medicine's Forum on Microbial Threats. He's had quite the prolific research career, and we're very grateful to get to hear more about his understanding of HTLV1, tuberculosis, HIV, and other infections, and has had, again, a prolific publication record, including over 500 articles, 48 chapters, 6 manuals, and 2 books. And I'm sure that I missed things. I'm very grateful that you're here, and I'll hand the floor over to you.
Thank you, Maya. For me, it's an honor to be part of these webinars and present some important disease from different countries. And I'd like to share right now will be very important for us to present this HTLV1. You know, we feel this is in the list of important disease we have in different countries, including my country, when we have different options to see this. I don't know if you are seeing my slides, Maggie, it's okay?
Yes, they're coming across great.
Yeah, okay. It's very important to discuss about this option to have HTLV1 as part of the viral disease. And usually, you know, we are working in Peru. I am Peruvian and working Cayetano, Heredia University. It's here in the front of the Pacific coast. We have Andes and we have tropical area from the Amazon, like Ecuador, Colombia, Brazil, Bolivia, etc. There are different countries who have Amazon regions in Peru. And we are studying this disease from the last 30 years, even more than 30 years, and we call this is so neglected disease, is not included in the list of neglected tropical disease, and also affect the poor people, increasing the poverty, the impact of mortality, morbidity, disability, and immunosuppressor still is not very well recognized. Only in the expert we discuss this topic, but that is not part of the standard. Remember, this virus was the first virus, retrovirus discovered from Dr. Bob Gallo in the 1980s. Even he discovered in 78, but he published the first paper in the 80s. And this is very important because it was isolated in the T-cell lymphoma. And second was the first oncogenic virus. There are not more oncogenic virus in relation to this. And this virus is very important because induce important number of malignant disorder. We discussed this. Also, this is a very ancient infection. There are different studies, especially with Annemie Van Damme in Belgium, and different groups about the transmission in the primates and humans, and sometimes the leukemia from the monkeys, etc., and subtype. This is very well studied. And also this is a Delta retrovirus, from a lifelong infection. This is very similar to HIV, usually infected CD4 and also CD8, and produce a spontaneous proliferation in PBMC in vitro. This is other topic important we need to remember about this virus. And this virus have usually two different problems. One is the persistent, and this was described from Charles Van Ham from UK, and he mentioned about the infections is a virus synapses, not cell-free, is pro-virus expression, have a polyclonal, and usually the dominant route of initial phases. And then you have the second part, that is mitotic part, and is related to cell polymerase, the cell division. You have latent provirus, and more important is the clonal expansion occur during these phases. That is, this virus from the science is very important because we have different views about why it's important this kind of virus. The first part of this, and this is important to remember, how much affected the human this virus. And the first one is important because can produce this mitotic cell cycle, and then you have cell proliferation, and you have malignant disease. That is, you have acute leukemia, you have acute lymphoma, then you have selective immune dysfunction, and that way you have the high increase in CD4, the FOXP3, and T cell altered from the cytokines. And the more important part of this, you have selective immune dysfunction, you have more tuberculosis, more strongyloidiasis, more cluster scabies, more deep mycosis, and that is important. And finally, the more selective part is inflammation. You have very important inflammation with the release of the cytokines, and this is important because the patient have tropical spastic preparation, the PSP-HAM, and then we have uveitis, thyroiditis, or even a lung disorder, and this is again very important part of the damage can produce this. But there is one paradox: 90% of the people are asymptomatic, but they can transmit the disease. That we call asymptomatic carrier, and it's important to understand why we need to looking about this and what is the way you can transmit it. That is the reason why today I choose the sexual acquired the infection. You can have a T leukemia or ATL, then you have HAM-TSP, you have infection, dermatitis, strongyloidiasis, tuberculosis, or other disease. That is the topic important to remember about the chronic carrier who can transmit this. The worldwide, this published from Antoine Jeswan, right now we know is more than 20 million. Probably this is sub-registered because even in different places it's not registered, mainly in Australia, in Japan, in Africa, in Brazil and Colombia, some Caribbean countries. However, right now you have more and more people. When you study this disease, you start to have more and more people involved. This study have a different limitation about the diagnosis methodology, change epidemiology trend, etc. This is what happened in my country, in Peru. You remember Lima is here, and then you have this focus about the Quichua population. You know, the Quichua is one ethnic group who are before Spanish came to the Americas, and this was part of the Incas Empire. And they have this virus in all these regions, including Cusco and all these places in the Andes. But also we have in the Amazon, in the native aborigine from the Amazon, we have also this kind of virus. Even in South America, the HTLV2 even is more selected infection, and we have very poor information about HTLV1 around the world. Around HTLV2, I'm sorry. And this is important to understand. We have two viruses from this family. The other important part is the impact in the life expectation. This is a study from Lloyd Eisen in Aborigine in Australia. And this is a typical Australian people who have this kind of mortality, but this is a people who are Aborigines. And then you can see how much they lose life. That is the life expectation. We have right now one paper probably submitted very soon. We have very similar data. And what is the comorbidity to explain why these people lose the years of their life? Have to have the virus, to have strongylosis, to have diabetes, to have alcohol. And this, again, very important to remember that it's not only oncogenic virus, it also reduce your life expectation. And that is, in my opinion, unfair. Okay, how you transmitted this? It's very important because we have three ways to transmit it. The first one is through the blood or needle infection, etc. That happened in the past in intravenous drug abuse in Europe and the United States and Brazil. But the blood screening is mandatory in endemic area. Peru have 25 years. We are doing screening, and Brazil have almost 30 years to have a screening in the blood donors, and this is important. However, everybody knows probably the more important part when you see patient is the mother-to-child transmission, and this is very important. Right now, the goal from the World Health Organization on PAHO is reduce the way the transmission. We need to make more research in this part because it's important to see this. And even right now, with Dr. Graham Taylor, Carolina Rosas, we are doing a strong group to try to make more research to try to reduce the mother-to-child. The experience conducted in Japan, in Okinawa, in Kyushu, proving this is very good intervention. For us, also, in addition to this goal important, is a sexual transmitted infection. And this is important because we have a different gaps right now. We reduce the gaps, but still we have a lot of questions. It's funny, more than 40 years with the HIV, we have gaps important in HTLV1, who is a part of the same family. Let me review you very careful about the transmission about this in couples. And Miyazaki is one cohort very well studied every year. They are seeing the patient. They have unbelievable support from the government. And then it's very important because the discordant partner, they increase as concordant partner with the age, the years of marriage, and the use have antitags and a high level of antibodies. Then we have more infection, more infected in non-endemic area in comparison with the endemic area. And finally, some of these people have very rapid progression to have some TSPs. And we are seeing some of the cases probably from the Brazilian and from the UK people. Also, in Brazil, they say in adults, the more important sources of the HTLV1 in Brazil, in Salvador, Bahia, is the sexual acquired. It's very classic associated with the syphilis. You remember the syphilis right now is explosive during the last 10 years with different reasons. The people reduce the condom use, the people are using PrEP, etc. The people who have HIV have a low virus low and have not contagious. For that reason, these two groups are not using condom, and this is one of the main reasons why we have so much syphilis. But the syphilis is associated with the transmission on HTLV1, and this is important. It's very similar to what happened in 4 cities in the north part of Brazil. And also in Australia, the association usually is increase the risk from male and the years to have and syphilis. Again, these syphilis appear in different styles. This is what we are doing in Peru. When we start to study female sex worker, because it's legal in some of the part of the female sex worker, we found very classic 2 steps. After the several years, the rate of infection could be as 25%. But the second part, and this was the first time we proven the condom use was protective in this patient. That is This was very important for us because this was the first study where the condom use was protected. Then we have in these women who are female sex workers and have HTLV1, we studied the interaction with the gonorrhea or chlamydia, and we don't found a lot of virus in the cervix. But what's more important when they have bacterial vaginosis? And bacterial vaginosis is one factor very common in the poor areas. Still, we don't know how they change the environment, the bacteria, and they have this kind of problem. And for us, it was important because, you know, the HIV, gonorrhea, and chlamydia are factors to transmit it. Then also we proved from the second time about the condom use protected from chronic ulcer, any other STD, and HTLV1. That was very important to try to prove in this. And again, the factor we found also in different studies was the syphilis. We have not too many facilities to study chlamydia, but syphilis and gonorrhea and HIV is very common to see. This is the reason why we feel it's important. In HIV, I'm sorry for this is in Spanish, but this was published from the people from Belgium in Africa. When they say the number of women who have HIV, the prevalence when they have normal flora is like 14%. And then when they have a bacterial vaginosis, it's almost 2 times, 26%. And again, this is important because that is the reason why in the poor country also the bacterial vaginosis give facility to transmit HTLV1. And again, this is important to remember because HTLV1 is intracellular virus. It's not in the plasma. And for that reason, it's important to remember, for instance, in pregnant women, the risk to have infected children is very, very low when they have not breastfeeding. The same in sex, you need to have some facilities, and one is bacterial vaginosis. And again, this is important for us. We have a different aspect. We saw not only in female sex work, also in men who have sex with men. The rate of this HTLV1 is very high, very similar. They found in Brazil also. That is, the high-risk group have a high level of HTLV1. And also we see in one study in females, we see how the female increase with the years. That is a cumulative risk with the partner, that the partner transmitted. And that is the reason why one woman start with 1 or 2% and finish when she have 50 years, they have 4% or 5%. That is our results when we study in 3 different ethnic groups, the mestizos, the African ancestor, and the Quichua people. We have the same rate of the infection in female. That is, the female is one of the main objectives we need to study in this condition. And also, they have other problems. This study published in PLOS 1 was conducted from Magali Blas and the group from Cayetano. They study in aborigine from the Amazon, and they look in HTLV1, HPV. And to have HTLV1 was strong associated with the HPV and high-risk HPV form, they have this patient. And it's funny because these people is a more isolated population. These Chipivos, Conivos are more isolated. And this is important because in the last year, the National Cancer published a paper about the HTLV1 in women who have cervical cancer. And the rate of the infection was very high, like more than 10% of these women have this. This is the comorbidity important in 2 sex diseases, and this is important because in our country, cervical cancer associated with HPV is one of the main causes of death in young women. Then recently we tried to do one study very similar to the cohort of Miyazaki. The difference is Miyazaki are doing every year. We have not economical support to do this in our country, and we are doing historical review, retrospective study historical, and this is important for us because we try to do this study. Okay, in these cases, we are looking only people who knows the mother or the family have HTLV1. That is in these cases. We call this is in these cases. And the partner is the current partner with whom the individual needs sexual activity with the partner. That is we call by definition. And then we use the concordant when the both people have infection with the HTLV1, and the second discordant is in this case is positive, but the partner is negative. This is the definition. Of course, what we use the moment we start to have the first clinical history, we use the year. They say, I am married 12 years, and I have this infection transmitted from my partner. But of course, this is the style, and I will discuss later the advisor from the statistical group. Because in our file, we have 12,000 patients enrolled, but we have almost 6,200 people positive. In this study, however, we are looking at this scan, and we found 394 eligible patients, 25 not mentioned year of relation, and we have 369 patients including this study. From this study, we have 181 in these cases by the definition we present, and then 188 couple of these. In this couple, we have 108 female in these cases and transmitted to male, and we have 80 male who transmitted to the female. That is the summary about this study. What we have here, the number of couples was 80 from male to female and 108. The rate of the concordant was almost 64%. And in the women to male is only 37%. That is the first conclusion is the difference in the transmission is very clear. The men transmitted very easy. Even in the years is very similar from male to female, etc. Then when we look in the characteristic, it's very important we use the male to female. What happened? The age usually is high. This is still we are trying to study about this is high. The year of relation is almost 2 times, but the women have very few partners. Usually they have 1 or 2 partners. These women are trained to be monogamous. For that reason, they have this condition. However, in male to transmitted to the female to male, you see here the age is 41, and the two have very similar. The year of relation is increased, but finally the number of partners from the males, they have a lot of partners, and this is part of the typical sexuality in the Latin people. And that probably, somebody say, this probably the risk. We feel no, the risk is to have a partner, and for that reason we use this data as important data. When we review the time of transmission, you see the men transmitted very quickly to these partners, and almost in 20 years, almost 75% of these women are affected. And this, when the women are, in these cases, the transmission is more slow. Let me make this presentation here. This is male to female transmission. You can see in the first 10 years, there are a lot of female, and here you can see this. But this is important because my group from statistics, they say, doctor, when you say the first time you make the clinical form, and then she say, I have 12 years of marriage. You don't know when she acquired, because you are not doing every year like Miyazaki. Probably you need to go to the middle. That is not 12 years, probably is the average to everybody. And they recommended to do that. And that is important because even if we using this statistical test, because they say, you say 12 months is 12 years, it's not the yesterday. They have probably in the last 12 years, and then we put in the middle. For that reason, the transmission is very, very important to see the male to female, and this happens with female. You can see this is very different. The first year is only a few cases, and then you have other person, and they have 15 years on the average. Again, this is important to remember because we feel this would be interesting to try to learn. That is, in summary from this, the men transmitted more easily to women. And that is true in different disease, in more acute disease. For instance, gonorrhea, when one man is affected, can affect 90% of the partners. When one woman is affected with gonorrhea, only 1 from 6 partners affected with the Neisseria. And this is again important because the transmission is through the semen on the cervix condition, but the cervix is more passive. It's different, no? You know, and again, this topic, in my opinion, is coming important. What progress and what gaps we have? You know, even until 2019, the World Health Organization have not any line about HTLV1. After we conducted the International Congress and Dr. Bob Gallo sent a letter to Lancet, that is the moment we start to have presence and the people are warning about what's happening with this disease is almost exotic disease. No, it's not exotic, and this sexual archive is related to the transplant, to blood transfusion, is related to the breastfeeding, and have a different disease. And right now, after years, PAHO and the World Health Organization mention about this, and the CDC start to mention the option to prevent HTLV1 because you prevent 2 cancers, HPV and HTLV1, can be prevented when you discuss the STI. But we don't know still the risk to have a transmission HTLV1 sexual assault or abuse sexual. We have not any number. The risk to have a screening when you have gonorrhea or you have syphilis is almost 0. Nobody's doing this, and we feel this is important. Right now, in our HIV, we published recently, when you have the 2 viruses, the mortality is high, and the life expectation is high when you have HIV and plus HTLV1. But we don't know nothing about we know the syphilis is a factor, but they are not a classic recommendation to have a screening when you have other STDs. What happened with the comorbidities? We know only with HIV and not with other co-infection. And finally, in any national STD program, STI program, including HTLV1, and it's very important to emphasize this because you can acquire this virus through sex. This is what happened in the guidelines in 21. The CDC don't include here HTLV1, but in these cases, the first time they recommended to try to review different, including HTLV. But recently, the World Health Organization in the 2024, this year, they included the list and including HTLV1. And also they mention this is a prevent disease, is unprotected sex risk factor, can prevent the vertical transmission, and you can prevent and management the complication. This is important, and right now they make the review about how much is annually invested in STI research, and you can see here appear a small part of HTLV1, and this is important because it's the first time that people start to thinking in HTLV1 as STI. One of the problems is we can have a malignant disorder. Dr. Takatsuki described very well before Dr. Gallo described. He described one epidemic from leukemia. This is Dr. Takatsuki. I have the honor to meet him. And the second part of this is Dr. Malpica in the MD Anderson review with the Latin America is a network from lymphomas. And what happened with the lymphomas is very important because the infection in the US, for instance, is 1.3 from 100,000. But in Latin America, it's 5 to 15% from 1,000. And this is very important because the risk to have lymphoma or leukemia, we call ATL, in the US, you see one is 20 20 cases per year. In Latin America, we are seeing 250 or 300 ATL every year. That is, this is the impact to acquire this infection. That is a malignant disorder. I don't mention other, but this is important. Even in our study, recently we presented in the Worldwide Congress from HTLV1, our cases, we have 220 malignant disorder from 4,300 people with ATL. Even we have people who have not ATL malignant, even cervical cancer or breast cancer, etc. But of course, the breastfeeding was the main risk to have malignant. But the sexual intercourse was the main sources and 10 of these patients. That is again, this the malignant disorder can see in people who acquire the sexual transmission. This is very clear because we make very extensive each case from this. For that reason, we recommended to study the family. When you have one case, we go to the mother or the sister or the sibling to try to see here if the infection is coming from the mother or moving from the partner. If she is a female, we go to see the children. If it is male, we go to the female. In that way, we can find. Why is important this? Because even you have breastfeeding or you have sex, we found between 20 to 35% of the family are positive. And this is important to remember because it's the best way right now to reduce the family screening. And of course, it's very important to have a good advisor because sometimes people say, you have very rare disorder, maybe you can die from leukemia or you have no treatment, etc. And that is unfair. You need to have a proper counsel. You need to have a very clear adoption of prevention. But remember, the diagnosis does not automatically lead to the prevention. You need to training and have education. The other problem is that we know the family aggregation from the diseases associated with this, and this is very important. For in this family, we publish about this family, how one of these diseases is sexual transmitted to the kids, and they 5 to 10 kids, they have HTLV1 carrier and 2 have HAM-TSP. That is, we affected the new generation about this. And finally, even with the malignant disorder, this is the grandmother who have lymphoma. She have 3 sisters. The 2 die from ATL. And then this lady have twins, and one of the twins died from ATL, young people. That is, again, this is very important to remember we can have this kind of disorder. And finally, to try to see, when the doctor, the people who try to review what happened with the infection disease, they say, the infection disease is trying to disappear. Yeah, but when you have a chronic infection, and that is becoming important right now, the people understand they are chronic with the COVID, post-COVID, etc. But in the past, we know different diseases are associated with cancer. And right now, this Dr. Fauci published this about the almost 16% of the cancer are associated with some bugs. This is a cervical cancer right now is almost 100% is associated with HPV, the gastric cancer associated with Helicobacter pylori, and then you have HTLV1 here, part of this cake about the option to have a lymphoma or leukemia. But again, this is a summary from the north and the south. When you see the north, only 10% of the cancer is associated with this. But then when you see the poor country or developing country of the south part of the world, is 20 to 25% of the cancer associated with this. And again, this topic is important for us to try to explain this disease, this neglected disease, because nobody cares, because it affects the poor people, and we have not the people who push to understand this process because they have a stigma. They say, you have one disease very similar to HIV, maybe you are promiscuous, or maybe you are gay, etc. The stigma is very common when we discuss this virus, because immediately they say, this is a brother from HIV, and you are promiscuous, you are gay, etc. And the stigma is coming back again and produce depression in the person because they are not promiscuous, they have only partner, and they transmit it from the partner. And sometimes the mother have a lot of depression to transmit it to the kids because they never saw the breastfeeding is dangerous, because the doctor will push to everybody to say, please, it's very important to have breastfeeding. And that is true. We promote the breastfeeding from different diseases to prevent. However, in some disease, we need to reduce the breastfeeding or try to look in drugs to reduce the provirus load. Because this disease, we never have a good plan of research, only in Japan, only in the European group. They have a lot of research. In the US, you have some important research. But then the difference is we have a lot of patients, but we have not the technology. For that reason, today I will present only clinical epidemiology, but I have not enough data to say probably the provider law in these women or these men are very high. Probably they have no circumcision because that is common in our country, etc. There are different factors we are not including in our study, but it's clear this disease is transmitted from men to women, and the more risk but the woman also transmitted to the men. That is the summary. And remember, this disease produces so many different organs. Remember, we have a cancer, but we have also, you have neurological disease with the tropical paraparesia. We have T-cell leukemia or lymphoma. We have uveitis because we have inflammation. We have chronic infection dermatitis. We have bronchiectasis and pneumonia interstitial. We have arthropathic poliomyositis. You have erectile dysfunction. You have complication with the strongyloides, cluster scabies, tuberculosis, leprosy, and HPV. And you have sometimes thyroiditis, etc. And finally, it's very important to have the care of the patient who have HTLV1. The first one is to try to promote the self-efficacy for healthcare. Have early identification of the disease. It's very important to train it to the people. And one of the places we can make this in the travel in the clinic of STI as the blood donor. We have the two main parts, and then we study the family. In family, and then you can prevent future transmission, like reduce the breastfeeding, etc., and you prevent disability. You can prevent the cancer when we study this kind of patient. I like to finish my talk, give my thank you to our group. It's very enthusiastic young people who have so many different activities. However, we save time to make a research in HTLV1, and that is the reason why we're very happy to be here and try to have the time to see if we can make some questions or some discussion. Thank you very much for your attention. I waited from any comment or any question.
Thank you so much for that enlightening presentation. We have a couple questions in the chat. I encourage others to add them as we start the Q&A section. So the first is from Raul. Hello, Professor. Congratulations on such a great lecture regarding this important neglected disease. What is your insight or perspective on the clinical trials conducted trying to look for the specific antiretroviral treatment for HTLV1 infection?
Still, we have not any treatment from the infection right now. We are doing some study, in vitro, some drug or retrovirus, special initial raltegravir, in combination with the ACT, can be useful in vitro. In clinical, we have very a small advantage to reduce the virus. Recently, the dolutegravir have a better in vitro, even the injectable from prevent the HIV also is very useful in vitro. However, we have not enough information to try to prove if we can do. Right now, in Brazil, as in Peru, we are reviewing our cases, especially the cases who have the co-infection HIV and HTLV1, and at least the first 5 patients, only one have high level of proviral load from HTLV1, but the other 4 have very low. That is probably the dolutegravir can be in the future in association with the tenofovir can be a good combination, but still we have not enough data. The treatment from HTLV1 is only proven in leukemia, acute leukemia. The interferon plus ACT or interferon plus lamivudine could be a good treatment, but they are not any specific. And the reason is very simple. They are not economical support from research. Only the last years we start to have some idea to have some research. And we feel probably dolutegravir could be an interesting compound from the near future. No?
Yes, I think that's a really important point, and that follows up on Laura had asked if there were any possible treatments, and you highlight that it was only recently that the economic support really started to be available for this. So clinical trials are certainly something that would be interesting, but we still have to have the in vitro studies first, right?
Yes.
Yes, take what we know from others. I see another question from Laura. Would you mind explaining if there are symptom differences between HTLV1 and 2?
Yes, HTLV2 is very uncommon disease. It's more related to the virus that have migration from the Bering Strait. This coming from the Aborigines from Canada, from the US, from Central America, and the Amazon. It's not seen in different places. In the past, we are seeing in the intravenous drug abusers in the European countries, because some of these people is coming from Africa, and then also have in some places HTLV2. But the information about the HTLV2 even is less. We know right now it looks like have a more mild disease. They are not very severe, but this is only a rapid view. We start to have a study in one places in Peru, when the same community we have the 2 virus, and we try to see how the mortality is different. The mortality with HTLV1 is high in comparison with HTLV2, etc. That is, but the clinical presentation still is very poor when we're looking from that. Only in Brazil, there are one group in Belém de Pará. They study a lot of the Aborigines from the Belém de Pará, and they found the same. The clinical presentation usually is not as severe as HTLV1, but we need to study more. That is, we need to understand in the better process the HTLV2.
Yeah, I think, again, your talk really did a good job of outlining how, so much research needs to be done in this area. Sten asks if you can comment further on what we know about the common nature of HTLV1 in endemic areas and cofactors for the relatively the rare neuro and oncogenic outcomes.
Yes, it's not only oncogenic. The people who are dying are coming. Let me mention this, and this is how we are seeing this disease. The people have 3 different ways. One is the cancer, but then when you review, they have cancer, but it's not the main cause. Then you have tropic spastic paralysis. When you have severe spastic paralysis, you finish in the bed and you have chronic ulcer, and they are dying from septicemia, and they are dying from the bladder, chronic disease with the problem with the bladder related to HAM-TSPs, etc. But then other disease, when you have severe strongyloidiasis, and you review, for instance, in your country, people from the North America or Europe, they have a very severe strongyloidiasis. When you give some immunodepression drug, or you have transplant, and you don't know the patient have strongyloiditis and then have very severe and is dying, the people are dying with the hyperinfestation, like 60 to 80% of these people even respond to the ivermectin, to strongyloides. Still the mortality is very high when you have disseminate. But then also we discover different deep mycosis. For instance, histoplasmosis, cryptococcosis, etc. And it's not only in HIV. We are seeing in non-HIV. Recently, this month, we published about the crypto in non-HIV patients, and one of the risk factors is to have HTLV1, etc. And you have more severe tuberculosis, you have more meningitis and tuberculosis, you have more bacterial load in the sputum and tuberculosis, etc. That is, you have more cluster scabies, you have more infection with this. There are different factors. You have more cervical cancer because the HPV is more active in the patients who have HTLV1. They are different. The problem is still we have not a good cohort. We have not economical support to try to see what happened. Only I can say, because we follow up years, different persons, we found this number, these different factors. But still we cannot answer in the totally how the people have this low mortality. For instance, in Australia, in the Alice Springs, where they're living the Australian Aborigines, they have a lot of pneumonia because they have bronchiectasis, and they are dying from pneumonia. And then when you review what they have HTLV1, and they have strongyloides, and they have bronchiectasis. And that happened in our countries. We have people who have a lot of bronchiectasis, not related to tuberculosis, because the bronchiectasis from these people is quite different from tuberculosis. In that way, you have this kind of factor, and sometimes even you have alveolitis or chronic fibrosis related to this because it's a chronic autoimmune disorder. That is, if you see, this is a very unbelievable spectrum. From my clinical experience, I see so many people who have, for instance, have uveitis, and some people finish blind from one eye because they have uveitis, and usually the intermediate and posterior uveitis have a mild clinical, but sometimes it's very severe clinical, and they lose the acuity, or they have a cataract very early, etc. But then you have thyroiditis. You have not a good diagnosis. The patient can have died from acute thyroiditis, and this is important. Again, this is inflammation. That is not only cancer, it's inflammation and all immunodepression. That is the broad spectrum I would like to emphasize about this disease. And this is very important to teach about the person. That is the reason why in the family you are looking different diseases. When you asking and make a good clinical history, you found different people with a different presentation.
I think you raise a really, eloquent point, and you called it an unbelievable spectrum. And I completely agree. I think the more that we learn, we're seeing that and appreciating really that viruses are playing a critical role acutely as well as chronically in inducing some of these conditions that we previously didn't associate necessarily with a virus or systemic inflammation.
Yes, I agree. I agree, Maggie. You remember in the past, there is a strong discussion from arthritis, from Lyme disease, and the infection disease, they say this is not an infection because the PCR and the culture is negative, but the patient have arthritis. And again, this is important because, the chronic form exists. In the past, when I tried to write chapter about the chronic brucellosis with my colleague from Turkey and from Greece, we have some problem with the editor. They say this not exists because you don't found the brucella. Say yes, but the chronic fatigue syndrome in these people right now with the COVID, you have only 2 or 3 years of the chronic infection. But HTLV1 is a lifelong disease, and that is important. This is a unbelievable material to do a good science with this virus. And with that good science, we can support a good global health and improve the quality of life for these patients.
Yeah, I think everything you said hits the nail on the head, that this is a neglected tropical disease and needs more research, and that there's the, as technologies have advanced, so have our ability to answer questions that we previously thought we couldn't answer. before, I want to make sure I'm being respectful of the questions in chat. Beatrice asks, is there any rule in other word law from the Peruvian government to control mother-to-child transmission?
We try to do this because it's still, for instance, the first part of this is very complex because Japan is the one single country who do this in Okinawa and Kyushu. They basically like $100 million to try to support these poor people from the south of Japan to try to stop. They make a screening any pregnant woman and stop and they reduce from 15% to 1%. Right now, the disease in Japan is more sexual acquired. It's not breastfeeding. But in Peru, we try, like other people in Latin America, we try to find what is the best way to reduce the breastfeeding. If you are a woman who have a middle class, you have electricity, you have water, and you have the money to have a artificial milk. But the first topic is you need to discuss with this person, because if you don't provide breastfeeding, you have a stigma in your family. What disease you have, you cannot give a breastfeeding, you start to have a stigma. But then when you are poor, and you have not water system, you have not electricity, you stop the breastfeeding, these kids have in 2 years, they are dying 10%. You know, it's, the breastfeeding is so important in the poor area. For that reason, we need to discuss what is the best system from the middle class, what is the best system from the poor part, where is endemic this. And this is important. This is part of the goal. The group from the PAHO, the Pan-American Health Organization, part of the World Health Organization, are promote this kind of discussion, research. Recently, we present in the International Congress about the interview we make to 43 women who have HTLV1. What is their opinion? Because it's very important to see what is their opinion. If you say you have you have the virus, can you stop the? And it's very interesting because this is the kind of approach we need to do. Right now, there are good data from Japan. They give it 3 months pure breastfeeding and the transmission was 0. That is probably in the future, we need to see how we can reduce the virus load in the mother, or maybe treatment from the neonatal, etc. But still, we have not the best answer to do this step. Of course, we need to have more research. My opinion is this is the best way to reduce the transmission. And usually when I have advisor, I ask into the mother, you have electricity, you have water system, you have money to support? They say, yes, okay, we recommend it to stop. But if you have not, we need to discuss what is the best way to do. Even sometimes when the mother stops the breastfeeding, they are cross breastfeeding. The aunt, the grandmother, etc., and they don't know the test. That is the problem. And that's the reason it's very important to understand the common practice in developing countries when you have a poor part and somebody, sometimes the mothers go to work, some member of the family provide breastfeeding. And this is important style you need to recognize and make it the best approach to have this kind of work.
Absolutely. I think the socioeconomic and cultural differences are important in understanding transmission and how we can leverage those to help stop outbreaks. I think we have another question from Franco. Very often the data show high frequency of HTLV in Aboriginal populations. Is there a difference in the transmission rate in different populations, Aboriginal versus different ethnical groups?
It's not very clear. It's different transmission we have right now the opportunity to try to see this in Peru because in Lima we have 2 groups. We study the mestizos, typical people who have different ancestors, and the Quichua. And the sex is sometimes the sexual behavior is different from the Quichua in relation to the mestizos. And also right now we know in the Amazon, the people who have early sex intercourse, they have more STI We have more syphilis, more herpes, more gonorrhea, etc. And for that reason, we need to see to answer that kind of question. We feel the problem in the small ethnic groups, they have a cycle of the sex and the family, and they have more different approaches, more complex when you see small places about this. And again, this is a social determinants who can provide more data about that question. But still, we feel the rate from transmission from sex is, in my opinion, still is very similar.
And then we have another question from Franco. Are there genetic predisposition determinants that we're aware of?
I'm sorry, can you repeat my question?
Are there specific genetic variants that are predispositions for severity of disease after HTLV1, like mutations in HLA genes or other genes?
From ATL, we have at least this is a 5 factor we recognize right now. The first one is more common to see in people who acquire through the breastfeeding. The second is they have a chronic infection dermatitis in the childhood. The third is to have strongyloidiasis in some moment in your life. The fourth is to have family with a malignant disorder, especially lymphoma or leukemia. And the 5 is a provirus low high. That is the biomarker, very important. That is the 5 criteria we are using to see the cancer people. We found these 4 is clinical, epidemiological, and 1 is the best biomarker. We know this is a high provirus low. However, you have in TSP also high provirus low. Still we need to have more data and see what happened. But this is I call 5 factors to have a high level of risk to have ATL.
No, thank you. That summarizes very nicely. And I think you've already answered this question about the association with indigenous populations.
Genetic?
Yes.
Yeah, it's not easy to study genetic, no? All the time, we like to do genetic factor, but it's not easy to study because you need a big number of cases positive and they make a test and they make the same in not infection people. This is a lot of money, a very high level of technology, and it's not easy to find the magic number when you study genetics. They say, we have 400. 400 people is not easy to prove it, the genetic factor. But I agree. For instance, I have one couple. These men have a tropic spastic paraplegia during 30 years. He started to have this very chronic problem. After 25 years, they start to use 2 cans. Okay. And his wife was affected. And then in 6 months, she is in wheelchair. That is the same virus in the couple. The 2 are Quechua, the 2 are the same ethnic background. He have a very low infection like his mother, but his wife made a rapid progression. And of course, if the same virus probably is related to some genetic factor, have this lady and this man have other factor, this is very simple to see the difference in some people. Probably it's genetic factor, but we are not sure from that.
Sure. And with that, I think we are at time. I want to thank you so much for an enlightening and engaging presentation. I've enjoyed getting to hear your talk as well as go over these questions and answers with you. I want to thank everybody who participated in this Q&A session as well. Thank you for putting in your questions. They've really added a lot to the discussion today. And we're of course grateful to our organizers and sponsors that made this webinar possible. And thank you for our technical team who helped us make sure that this could run smoothly. Anyone who was unable to join or joined us late and would like to revisit any part of today's webinar, the recording will be available shortly. And we'll send out an email with the link to the recording along with any additional resources and contact information, of course, for our speaker. And I want to remind you to stay connected on social media, visit our website for updates on upcoming events and initiatives. Our annual meeting is being held in Durban, South Africa this year, and the registration link is live, so please check it out. We hope to see many of you there. And then once again, thank you for joining us today. Thank you, Professor. We hope you found this webinar informative and inspiring. I sure did. And we look forward to seeing you at future events like the next webinar on July 30th. And this will conclude our Forefronts in Virology webinar. Stay persistent, resilient, and let's all keep innovating faster than these viruses can mutate. Thank you. We'll see you next time.
Thank you, Maggie. Thank you, Ruby, also from all your help.
Yes, yeah, none of it happens without Ruby.
Yes, okay. Bye.
Bye.